Assalamu alaikum and Bismillah Rahman Rahim. This is Dr. Narmeen Haseeb, lecturer at University of South Asia. Today we are going to discuss about spinal cord injuries. So let's discuss the objectives. Today we will learn about the classification of spinal cord injury. We will learn and discuss about the central cord syndrome, Brown-Sequard syndrome, anterior cord syndrome, quad equina syndrome, Cybora, and at the end we will discuss the rehabilitation required for spinal cord injuries. So with all the good vibes and positive energy, let's start our today's lecture. First of all, we will discuss about the classification of spinal cord injury. Basically, there is an impairment scale which is given in order to know the classification of spinal cord injury. The scale is known as American Spinal Injury Association Impairment Scale. The scales help us in order to know the level of injury. So the classification is based upon assessment of strength and sensation to light touch and pinprick. And this one is defined in myotomes and dermatomes. So according to the myotomes and dermatomes, you can assess the strength and sensation to light touch and pinprick. After completing this scale, the examination on child, it requires certain level of maturity in being able to follow the motor commands and respond appropriately to sensory stimulation. The examiner must take this into account when assessing children. Other factors that may limit examination, example, the long bones and the need to be taken into account as well. So the scale is just about the appropriate knowledge of the child and his maturity to be able to follow the motor commands and to be able to respond appropriately to the motor sensory stimulation. So the first part of this scale is about motor examination, which scores on a 6-point scale from 0 to 5. For each strength grade, the joint being assessed must be moved through available range of motion. Then a strength grade of 0 is given for total paralysis. The grade 1 is given if it's visible or palpable contraction that cannot move the joint through its available range of motion with gravity removed. Grade 2 is given to the individuals whose muscle group can move the joint through the range of motion with gravity being removed. The joint is positioned parallel to the ground to limit the effect of gravity. A grade 3 is given when the patient can move the joint through the full available range of motion against the gravity, but cannot bear any additional resistance. If a patient can bear additional resistance, they are given a grade 4 and a grade 5 is given for normal strength. Motor scores are documented on the ASIA form and summed up for a total motor score. So that's how the motor examination is being done from scale 0 to scale 5. You just have to follow the instructions and calculate and assess the strength, the power that is being found in the muscle of the child. After that, a rectal exam must be performed to assess for voluntary contraction and is scored as yes or no. As individual muscles are almost have been innervated by multiple spinal cord levels, a strength grade of 3rd is considered normal for a muscle group if the level above has grade 5 strength. This implies that the grade 3 muscle group is only partially innervated and the more proximal innervation level is intact. So when you are going for rectal exam, you can either score it yes or no. For sensory examination, you can use pinprick and light touch as key points. You can grade it as 0, which means absent, as 1, which means impaired, and 2 as normal. These results are summed up as well for total light touch and pinprick scores. Again, a rectal exam is necessary to assess the anal sensation. Also, the rectal exam is again going to be scored as yes or no. So you are going to do the motor examination with grade 0 to 5 and then a rectal exam and going to score it as yes or no. Then you're going to perform the sensory examination and grade it as 0, absent, 1, impaired, and 2, normal. And at the end, you are also going to perform the rectal exam for the anal sensation and going to score it as yes or no. Now we will see what is central cord syndrome. When the damage is being done on the central area of the spinal cord, that's what central cord syndrome is. This is most commonly the one which happens in the cervical region. And what basically happens is there is disruption of decussating spinothalamic fibers at the site of lesion. So at the site of lesion, there is going to be disruption of decussating spinothalamic fibers. And this will result in impaired pain and temperature sensation at the dermatomes. So the dermatomes being involved will be resulted in impaired pain and temperature. There was decussation at the spinothalamic fibers, and it was common in cervical region, and this was associated with the damage of the central area of the spinal cord. Dermatomes above and below the lesion have normal sensation. They do not have any kind of problem. As the lesion enlarges, the damage may extend into the interior horn cells and medial cortical spinal tracts, causing the weakness. So, revising these points, we know that damage is in the central area of the spinal cord. This is more common in the cervical region. The disruption of decussating spinothalamic fibers occurs at the site of the lesion. The fibers above and below are just normal. This results in impaired pain and temperature. As the lesion enlarges, this may result into the weakness. The reflexes may be lost at the level of lesion and with a possible hyperreflexia at the lower levels. As this is primarily a cervical syndrome, so there are typically motor and sensory changes in the arms as well. But the legs, bowel, and bladder function are all spared. So what's more affected? The motor and sensory changes in the arms are more affected, and the reflexes may be lost with possible hyperreflexia at the lower levels. The next one we have is Brown-Sequard syndrome. Brown-Sequard syndrome results when there is hemisection of spinal cord, when there is just hemisection of spinal cord, and it most commonly is seen with low speed penetration wounds such as stabbing. Corticospinal tracts in the dorsal column cross in the brain stem. So their damage in this type of lesion leads to ipsilateral weakness and loss of vibration and position sense. So there is ipsilateral weakness and loss of vibration and position sense. The lateral spinothalamic tracts cross soon after entering the spinal cord, thus causing contralateral loss of pain and temperature sensation. So there is going to be the weakness and loss of vibration and position sense on the same side of the lesion, while the loss of pain and temperature sensation will be on the opposite side of the lesion. And this type of syndrome is caused by the low penetrating wound such as stabbing, and this is because of the hemisection of spinal cord. Now we have interior cord syndrome. Interior cord syndrome is most commonly related to the vascular insult causing infarction of the ventral spinal cord. Whenever there is a vascular insult that causes the ventral spinal cord infarction, that is interior cord syndrome. This type of syndrome includes the corticospinal, spinothalamic, and descending autonomic tracts to the bladder. So this results in urinary incontinence, paralysis, and loss of pain and temperature sensation to the bladder. Then we have quadra equina syndrome. So the quina equina syndrome is the one which is basically associated with the compressive injuries in the lower lumbar and the sacral vertebral levels. This may result in damage to the quadra equina. As the spinal cord proper has terminated at a higher level, this results in scattered symptoms. Depending upon which nerve roots are damaged, the quadra equina syndrome results in damage to the axon of the lower motor neurons, leading to flaccid paralysis. So how do we differentiate quadra equina syndrome from the other syndromes? Because this is the damage to the quadra equina because of the compressive injuries in the lower lumbar and sacral vertebral level. It results in the scattered symptoms, and there is damage to the lower motor axons, leading to the flaccid paralysis. Then the last type of syndrome we can have is SIWORA. This is spinal cord injury without any radiographic abnormality. So let's see how is this possible. The initial definition focused on children with traumatic spinal cord injury who did not have evidence of vertebral column injury on spine X-ray, conventional and commutative tomographic studies. myelograms, or dynamic flexion extension studies. This included injuries caused by penetrating trauma, electrical shock, obstetric complications, and congenital spinal anomalies. So basically, there is traumatic spinal cord injury, and there is no such evidence which comes on X-rays or CT scans, but there is an injury, and this type of injury is going to be excluded from the penetrating injuries, electrical shock, obstetric complications, and congenital spinal anomalies. The early treatment required for spinal cord injuries includes spinal stabilization. In spinal stabilization, we can use the halo-external skeletal fixation devices and thoracolumbar spinal orthosis. Other than spinal stabilization, use of steroids can also be done. You can use methylprednisolone, that may be of great help in spinal cord injuries. In order to manage the respiratory function, all children with acute spinal cord injuries should have a respiratory function evaluation. For urinary function, flaccid bladders need to be drained either continuously or intermittently, while clean intermittent catheterization can also be done. For gastrointestinal function, after acute spinal cord injury, the gastrointestinal tract usually stops functioning initially. Thus, requiring the use of nasogastric suctioning is possible. Once the ileus is resolved, the child is taking enteral feeding, a bowel program should be instituted, with the ultimate goal of continence in impaction. The consistency of the stool is normalized through the use of fluids, fiber, and medications as needed. Evacuation is assisted through the use of digital stimulation or oral or rectal medications. So, in short, what's happening is for gastrointestinal function, you need your main goal is to continue continence without impaction, and you need to assist the evacuation with the help of use of digital stimulation or oral or rectal medications. Fluids and nutrition needs to be monitored. For rehabilitation phase, mobility needs to be focused. Self-care and activities of daily living needs to be worked on. For levels of cognition, you need to check on the scores of cognition, on what cognitive level the child is on, and considering that, using some kind of the scores available for cognitive level. After calculating the score, you can go on with your rehabilitation plan. For bladder management, first of all, you need to know that after spinal cord injury, the bladder becomes neurogenic, which makes the bladder hypotonic. So, with hypotonic bladder, what is required? An indwelling catheter, which is typically used and placed to drain the bladder. So this type of catheter protects the bladder and kidneys and allows close management of fluid status. It's easy to manage, and long-term use of indwelling catheters may lead to risk of UTIs, urinary tract infections, shrinking of the bladder, stretching of the sphincters, breakdown of the urethra. So using an indwelling catheter as soon as possible is very much the need of acute period, but you along with the use of indwelling catheters, you need to continuously monitor the risk that comes for UTI, shrinking of bladder, stretching of sphincters, and breakdown of the urethra. So the goal of bladder management is basically to gain continence of urinary bladder, promote independence, minimize urinary tract infections, and protect the kidneys. Voiding pressures need to be maintained less than 40 centimeter H2O to minimize the risk of urethral reflux. So during the acute phase, baseline evaluations of renal and urinary function needs to be performed. These include blood urea nitrogen levels, serum creatinine, urine analysis, urine culture, and renal ultrasound, or otherwise intravenous pyelogram. So when the patient is out of the spinal shock, they should undergo the urodynamic testing. Other than that, clean intermittent catheterization or the intermittent self-catheterization is method most commonly used today for bladder management after the spinal cord injury. External sphincterectomy may be considered for continuously draining the bladder. A surgical procedure such as mitral FANOF procedure may be used to ease self-catheterization. Basically, this procedure creates a stoma in the abdominal wall, typically through the umbilicus, which allows easier accessibility for catheterization. Medications, in order to treat the urinary tract infection, antibiotics are being given for prophylaxis with catheterization program to treat asymptomatic bacteriuria. So you can give medications as a prophylaxis for UTIs. For that, other than that, cranberry juice can be given. It also prevents the urinary tract infection. Anticholinergic agents can also be used, which relax the urinary bladder and results in larger bladder capacity and decreased bladder pressures. Commonly used oral agents are oxybutynin, tolterodine, imperamine, hyoscyamine, and these are the oral agents which are used to prevent and treat the UTIs. Other than that, the side effects of these oral agents can include the dry mouth, decreased sweating, blood vision, heat tolerance, and constipation. So you need to monitor all these things together while you are giving these oral agents. For neurogenic bowel, with the loss of neural control, the gastrointestinal tract loses its voluntary control and peristalsis slows. So, other than that, for respiratory function, a close attention should be given to monitor the pulmonary function during the rehabilitation phase. For nutrition, adequate nutrition needs to be monitored in order to promote the healing of injuries and provide energy to participate in the rehabilitation process. For skin, pressure ulcers are a common complication of pediatric spinal cord injury and are caused by pressure. Shear and friction with moisturizing are complicating factor. So the next thing we have is autonomic dysreflexia. Dysfunction of the autonomic nervous system after spinal cord injury or above T6. This is going to occur as a result of noxious stimuli, which occurs below the level of injury. So there is increased sympathetic activity that will lead towards the vasoconstriction, that too below the level of injury, and hypertension. Symptoms of autonomic dysreflexia include pounding headache. There is going to be very pounding headache, sweating above the level of the lesion, red splotches on the face and neck, and nasal congestion. So bradycardia may also be present, and the inciting factors are bladder and ball distension and rapid change in position from sitting to supine. Urinary tract infection, renal or bladder stones, and suppository or enema insertion may also be inciting factors. Treatment depends and is done by resolving the inciting factor. So autonomic reflexia is just the increased sympathetic activity that leads towards the vasoconstriction below the level of injury and also the hypertension. So because of a result of a noxious stimuli, two things are going to happen: the vasoconstriction of below the level of injury and hypertension. The other thing that can happen is hypercalcemia. Most likely, it is going to occur in adolescent boys in the first 2 or 3 months after the spinal cord injury. What is happening? Basically, the serum calcium should be routinely followed throughout the rehabilitation inpatient course, and treatment with fluids, furosemide, and calcitonin should be instituted as required. Deep venous thrombosis can also be a complication of this, along with pulmonary embolism, and they are potentially life-threatening complications of spinal cord injuries. The most common time of occurrence is during the first few weeks after the spinal cord injury. Recommendations for prophylaxis against DVT in pubertal children include low-dose heparin or low molecular weight heparin. Calf compression pumps can also be helpful. Late occurring DVT most commonly occurs in increased immobilization related to illness or surgery. So there can be a complication of DVT and pulmonary embolism. As a prophylaxis, you can use the low dose heparin, low molecular weight heparin, or the calf compression pumps. Both can help you out. Then there can be temperature regulation. The children with spinal cord injury above the level of T6 frequently have problems with temperature regulation. So, because they lose their control or central control of sympathetic and voluntary muscles, they must thus dress according to the environmental temperature. And before investigating the source of hyperthermia or hypothermia, investigation should be made into the temperature of the environment where the child has been. Often undressing the child or putting the blanket over the child is all that is necessary to treat hyperthermia or hypothermia. So there is no need to panic. All you can do is put a blanket over the child, or you can, undress the child. That will be enough. Other than that, the stuff, the material you're using for the child can be made of latex, and latex can lead to an anaphylactic reaction. So the caregivers need to be very competent, and they should understand that any kind of latex surgery it should be, you know, should be immediately uh, told to the doctor, to the consultant, and it should not be avoided. In case of spasticity, approximately 50% of children who have spinal cord injuries are going to suffer from spasticity. So this is more common in the children who will have incomplete lesions. So all you can do is you can improve the range of motion, you can maintain proper positioning, use orthotic devices, splinting may be done, medications to treat the common spasticity can be given, equipment and environment are both to be focused, and wheelchairs can be arranged and orthotics are important. So now we will have a quick review, quick summary of what we have studied in spinal cord injuries. The classification is based upon assessment of strength and sensation to light touch and pinprick in defined myotomes and dermatomes. The motor examination scores strength on a 6-point scale from 0 to 5. Sensory examination is performed using pinprick and light touch at key points. The damage to central areas of spinal cord, this most commonly happens in cervical region. Disruption of decussating spinothalamic fibers at the site of lesion results in impaired pain and temperature sensation at those dermatomes. This is known as central cord syndrome. Brown-Sequard syndrome results from a hemisection of the spinal cord. This is most commonly seen with low-speed penetration wounds such as stabbing. The interior cord syndrome is most commonly related to vascular insult causing infarction of the ventral spinal cord. Compressive injuries in the lower lumbar and sacral vertebral levels may result in damage to the quad equina as the spinal cord injury, spinal cord proper has terminated at high level. So that was all for our today's lecture. I hope you guys are clear with the concept of spinal cord injury and their rehabilitation process. Until next lecture, take care of yourselves. Allah Hafiz.